Good afternoon, everyone. Thanks you for joining us today, and welcome to today's session. We'll be starting shortly in the next 3 minutes, so to allow some more members to join. Thank you. I'll present the International Hospital. Her name is Vanessa Mokera, a registered dietitian nutritionist. Well, she's quite dedicated in matters to do with clinical nutrition and has a passion for gastroenterology and sports nutrition for that matter. And we've seen her before doing a presentation on other subjects, and we'd want her to enlighten us on this particular topic for us on immobility-induced muscle atrophy, so that perhaps we can be able to better our knowledge in terms of how should we manage these particular patients when it comes to nutrition. So without a further ado, welcome Ms. Vanessa, and take us through. And perhaps you'll be using the Q&A section for your questions, so that now they can be answered at the end of the presentation. Welcome.
Thank you so much, Mr. Agri. From the title, today we'll be going to discuss nutrition in immobility-induced muscle atrophy. It's a very wide topic, but we're just going to get a short summary for today's session. We can plan maybe in the near future to have other sessions to just dive deeper into this topic. So we're going to start with basic definitions. What is atrophy? For you to be able to manage or get nutrition strategies for it, you first have to understand what we mean by muscle atrophy. And it's basically the progressive loss of skeletal mass, strength, and function due to prolonged physical inactivity. This is specific to immobility-induced muscle atrophy. It arises from a disruption of normal muscle protein balance, where breakdown outweighs synthesis, leading to structural and functional decline. So etiology, we have mechanical unloading or disuse, immobilization, caused by a rapid atrophy in anti-gravity muscles such as quads and calves. About 3 to 5% of limb muscles can be lost in just a week. And then another type of atrophy we have, or etiology, sorry, we have one in molecular pathways, where we have decreased muscle protein synthesis and relatively increased degradation via ubiquitin proteasome, early increases in oxidative stress and inflammation that promote catabolism. Still in etiology, We have central or peripheral nerve injuries, such as stroke, spinal or peripheral neuropathies. And this is usually with losses of going up to 95% of bulk. Some of the risk factors in muscle atrophy include duration and degree of immobilization, where muscle loss begins within hours. Strength decline can go up to 40% in just 1 week of immobilization. Another is age. Older adults lose muscle generally faster and have slower recoveries. And then we have neuropathies and chronic diseases such as cancers, HIV. And then we also have medications such as glucocorticoids that may worsen muscle degradation. We would like to know some of the clinical manifestations, and we've got muscular, where there is rapid loss of muscle mass and strength in weight-bearing muscles, fatigue, reduced endurance, difficulties with standing, climbing, and gait, and that you can assess with functional assessments. Clinical manifestations in the structural. We have muscle fiber atrophy, decreased cross-sectional areas, joint contractures, and reduced range of motions. And then systemic clinical manifestations include bone demineralization, cardiovascular conditioning, insulin resistance, increased risk of pressure ulcers, and deep vein we also have deep vein thrombosis, which just reduces independence, especially in the elderly. Next, we just want to have a few insights on muscle atrophy. And I'd like to just start by defining what a muscle is. A muscle is a soft tissue made up of fibers or muscle cells that contract to produce movement, maintain posture, and generate heat. It's basically the biological machinery that lets you run, speak, breathe, blink, and laugh until you cry. A muscle is made up of muscle fiber packed with myofibrils, which are bundles of contractile proteins, actin and myosin. It also contains myofibrils that contain sarcomeres, which are the smallest contractile units. Also, a muscle has connective tissue wrappings and motor neurons. Type of muscles that we have, skeletal muscles such as the biceps and the quads. We have cardiac muscles. We have smooth muscles that are the gut walls and blood vessels. And just fun fact, muscles actually make up 40% of your body weight. And the strongest muscle relative to size is the jaw muscle. So fun fact. Types of atrophy, I had already mentioned, maybe we can just go through it again. To give insight, we have the disuse or immobility induced, which is our main focus today, where there is reduced mechanical load that decreases mechanistic target of rapamycin signaling and increasing ubiquitin proteasome system activity. And then we have neurogenic atrophy, and some of the causes are disease or injury of motor neurons. Mechanism, lack of neural input that leads to a rapid loss of muscle size and fiber transformation. And then another type of atrophy, we have cachexia. Causes are chronic diseases like cancer. Mechanism, we have systemic inflammation increased systemic inflammation, and metabolic changes that just cause profound catabolism. The other type of muscle atrophy, we have sarcopenia, which is age-related muscle loss and is associated with hormonal decline, mitochondrial dysfunction, and chronic low-grade inflammation. So what are the current nutrition strategies for immobility-induced muscle atrophy? Nutrition strategies that are currently in place are focused on protein intake, micronutrient supplementation, timing of meals, and hydration. And that's where our main focus is going to be today. So maybe if we can start with the protein intake. Adequate protein is crucial. And we generally have higher intake for patients with immobility-induced atrophy of about 1.6 to 3 grams per kg body weight per day. And this shows protective effects in energy restrictions and disuse models by supporting muscle protein synthesis. So the protein is ideally distributed evenly around 20 grams to 40 grams across 4 to 6 meals is feasible. This pattern stimulates muscle protein synthesis. And then we have a bit of a focus on leucine-rich sources such as whey and animal complete proteins. And studies have shown reaching 3 grams leucine per meal really does maximize MPS or muscle protein synthesis. It has also been found that consuming 20 grams casein or slow digesting proteins just before bed, around 2 hours before bed, supports overnight synthesis and helps retain muscle during immobilization. And then on micronutrient supplementation, essential amino acids with still emphasis in leucine preserves muscle mass during disuse and activates mTOR signaling in the mechanistic and animal studies that have been done. We also have beta-hydroxyl methylbutyrate, which is a metabolite of leucine that supports muscle preservation. It also reduces breakdown and aids reloading post-disuse or immobility. It is effective clinically and in older and bedridden patients. Other compounds such as creatine and collagen also support repair and overall anabolic environment, with 5 grams creatine and collagen 10 grams per day being very effective. And then there is importance of vitamin D for calcium absorption, which is vital for muscle contraction and overall muscle health. And an approximate of 40 to 60 nanograms per milliliter is advised per day. B vitamins are also important, including B6 and B12, and are involved in protein and carbohydrate metabolism, helping convert food into energy for muscle function and repair. Calcium is crucial for muscle contractions and nerve signals, which are essential for muscle protein synthesis, as well as muscle function. And about 1,200 mgs per day to 1,300 mgs per day are recommended. We also have zinc, which plays a role in protein synthesis, cell division, and immune function, all of which are very important for muscle growth and repair. When it comes to meal timings and frequency, it is recommended to evenly distribute protein across the day with around 4 to 6 servings to consistently stimulate MPS. There is one proximity to activity when there is anabolic stress of about 30 minutes post-resistant training or physiotherapy for our clinical setups that offers potential gains. However, we have emerging data that suggests that the window is broader, not necessarily confined to the 30 minutes. It can go all the way up to 24 hours. So boosting meals within this period with essential amino acids does help to overcome the anabolic resistance. And then hydration. So a typical adult needs around 2 to 2.5 liters total water. And whenever exercise is involved, there is related hydration to replace of about 1.25 to 1.5 liter per 1 kg body weight lost around exercise. So basically this fluid, the hydration post-exercise is supposed to be with electrolytes, and you can give 40 to 100 millimole per liter sodium. And then during immobilization, still in hydration, though fluid loss is less, though there is less fluid loss, your hydration is important. And so you can give the normal 2 to 2.5 liter for an adult, as it supports metabolic processes and nutrient delivery in muscles. So what are the timelines of the muscle loss? When can you start seeing actual losses, or when can you start expecting losses in the clinical setups, or even at home for bedridden or very sedentary persons? So short periods of muscle disuse lead to significant decrements in muscle mass. Within 1 week, we are able to see 1.7% decline in just 2 days and 6.7% lost in 7 days. And there was a study done by Kilroy, 2020. This was mostly done on young men, and it was seen just 2 days post-immobilization, limb immobilization. They got 6.7% total muscle loss in 13 of the sample group. And then patients who underwent total knee replacement surgeries experienced an 18.4% decline in quads muscles over 6 weeks. So this is within the 1 month period. This is equivalent to around 0.44% muscle loss per day, according to Dreyer et al., 2013. Another study observed 17% quadriceps reduction after 6 weeks of just casting. That is around 18% in 42 days. So by 90 days, which is around the 3-month window, 90 days of bed rest, studies show 15% quad loss and 29% calf muscle loss. Data beyond 3 months is limited at the moment, but extrapolated trends show an early rapid loss that then tapers around the 4th, 5th month period. Typically, another 5 to 10% loss accumulates between 3 and 6 months, with more in critically ill individuals and individuals with chronic illnesses. So in the previous slides, we've mentioned proteins over and over, and would just like to understand what's the role of protein in muscle and why is it so important to us. So let's explore how protein isn't just a fuel, it's an architect, a repair crew, a signal caller for muscle maintenance and growth. Essential amino acids and resistant training, or in clinical setups, basic physiotherapy. According to Brooks et al., 2008, demonstrated that essential amino acid supplementation during 28 days bed rest, when paired with physiotherapy, retained up to 60% more lean mass. Leucine-rich foods appear especially potent in elderly and sedentary populations. Think of essential amino acids as the spark plug that keeps protein synthesis alive during disuse or immobility. So muscle protein breakdown and muscle protein synthesis mechanism is still interrelated with the role of protein. And breakdown and synthesis maintains a state of balance, remodeling of proteins in the muscle tissue. Muscle protein breakdown works in different systems with proteolytic activity to just break down proteins and release peptides and amino acids into the intracellular pool of the muscle. Ingestion of meals containing protein stimulates a transitory increase in muscle protein synthesis and a decrement in muscle protein breakdown, resulting in a positive state of muscle protein balance. Meaning, if your patient is getting the 1.6 to 3 grams per kg body weight of protein, you will have an increase in the muscle protein stimulation and a fall in the breakdown, thus a positive balance. And this goes with the earlier mentioned study by Brooke, and you will have around 60% more lean mass at the end of the day in comparison to a patient who is not meeting the 1.6 to 3 grams per kg protein per day. Key statistics on muscle atrophy. We've got We've got 30 prevalence of muscle atrophy. About 30% of patients who are immobile or immobile persons are prone to losing muscle or the catabolic nature of immobilization. And then we've got around 15 days of immobility that causes significant impact on functionality. And it's even worse for our elderlies who have issues to do with self-feeding at this point. Functionality drops. And then we also have an increased annual healthcare costs, with it going all the way to around 5 billion. So what are some of the interventions that we can put in place to help combat muscle atrophy. For nutrition focused, we have supplementation, increased high biological value proteins, and proper hydration. Implementing nutritional strategies is essential for recovery from immobility-induced muscle atrophy, and it does require adequate protein intake and generalized balanced meals to help enhance muscle repair and overall health during the rehabilitation phase. So supplementation will be mostly focused on the essential amino acids, and this helps preserve 75% of muscle mass during 28 days of bed rest. About 15 grams essential amino acids 3 times a day for 10 days reduces lean mass loss from 2.66 kgs to just 1.59 kgs in elderly patients. Creatine supplementation reduces inflammatory cytokines and supports recovery. In a landmark study by Brooks et al., 2008, we have participants who received 16.5 grams essential amino acids alongside their meals 3 times a day during the 28-day bed rest. And the results, a retention of 75% muscle compared to 35% losses in the control group. And then we also have increased high biological value proteins still in the interventions. And we are pro complete proteins, giving meats, beef, chicken, and also within the interventions, we have proper hydration of the 2 to 2.5 liters per day to aid in because muscles are still made up of water. And then still within the strategies, as earlier mentioned, we do have micronutrient supplementation. There is profound impact on micronutrients, and these are basically the vitamins and minerals as earlier stated, because they play a crucial role in the recovery. As earlier mentioned, in immobility, we've got 35 to 40% reduction in muscle mass, and inadequacy in protein intake can significantly increase this percentage, going up to around 70% as seen in studies by Brooke earlier mentioned. So adequacy in protein will help mitigate and reduce the percentage in muscle mass loss. So for successful intervention cases, we've had a few trials done in the ward setup, where we had, in the orthopedic ward, we had patients who were on traction, non-ambulant, bedbound, and we supplemented essential amino acids, 10 grams per day for 20 days. And what we noted was increased functionality within the 3 months, within the 6 weeks post-traction. And there was also significant retention of lean muscle mass. We also noted that most of our patients who are also having wounds at the time had improved wound healing, and some even went ahead to proper heal without grafting, where earlier needs had been had been noted. The essential amino acids that was mostly used in the ward setup was AminoGuard. A sachet has 5 grams, so we were giving 2 sachets a day for an adult patient. So in summary, just to wind up, we have noted that protein sources, essentially protein is very important in mitigating immobility-induced muscle atrophy. And we are pro high biological value proteins. We are also pro essential amino acid supplementation, going to about 10 grams per kg body weight per day for an adult. And then proper hydration is essential, as earlier mentioned, to just support metabolic functions and nutrient delivery to muscles. Essential macronutrients, as earlier mentioned, boost immunity and also help with proper muscle functioning. And generally, it's not just about proteins. The meal has to be balanced. So a plate that is balanced equals a happy patient or a happy individual. Thank you.
Thank you very much, Vanessa, for that presentation. So the floor is open for the Q&A, so that now we may be able to, we are taking now the questions which are on the, you can type your questions in the chat. Thank you very much for enlightening us on this topic about muscle atrophy, of which I believe, especially, it's quite common in our orthopedic patients in the wards, because you get like those are the most prone patients to be immobile, especially when they're on traction. You find that within no time you start getting muscle atrophy because they're not moving around as it should be. So if we go into the Q&A session, perhaps we have one question here. I believe it's a concern from Odio, sorry. He's asking, how do you sustain the fluid equilibrium in a person with hypertension to restore fluid loss? That is after exercise. And he's having some sentiments there. He's saying, I believe extra normal saline ingestion is contraindicated. So what is your take on this matter in terms of concerns to do with patients who are having hypertension and having to do some form of exercise? And how do you restore their fluid loss? Well, if I can just take that question and perhaps answer is in terms of, you see, on instituting management of patients, it should be more or less tailored to meet their requirements as pertains to their health. Because I don't believe someone will just give general advice to these particular patients. So whenever you're dealing with such patients, you definitely must have some bit of the clinical history of this particular patient, what is ailing them, so that now you can be able to institute measures that will be able to address their concerns health-wise, vis-a-vis maintaining their normal health balance. So even in terms when it comes to achieving fluid equilibrium in this kind of patients, it definitely goes without to say it has to be monitored so that now you're able to, because your concern here would be fluid retention, perhaps, this kind of patients, because you'd want to recommend a reduction in consumption of sodium so that now you're not retaining more fluid in these particular patients. So it should be more of individualized care. It's not more of a generalized kind of care. So, and I believe this presentation is giving us insights in terms of what should we be cognizant of during the management of these patients. So we have to take the patient wholesomely. It's not really more of one size fits all for all kinds of individuals that will be managing. So thank you very much for that particular question. There is one from an anonymous attendee who is asking, what are your thoughts on protein powder supplementations in regards to increasing protein intake?
Okay, thank you for that question. So when it comes to protein powder supplements, as earlier mentioned, everything nutrition is very individualized. So depending on what the person is going for, you can supplement. However, dietary is the best way to go. You'd still want to maximize on your dietary intake first. Where needs are not met or where there are deficiencies or inadequacies, then we can go for protein powders, but it also depends on what the goals are for the particular person is.
Well, another, I think this is more of a comment whereby she's commending you and thanking you for the elaborate presentation. And she's asking if we can get the slides of the presentation. So we have a recording which is going to be uploaded on the KNH website, so you can get the presentation from there. We have one from Mercy here. This is now a comment, I believe. She's saying dehydration can be a concern for individuals with hypertension, and as it can both increase and decrease blood pressure, so potentially worsening their condition. So while dehydration can cause blood vessels to constrict, leading to higher blood pressure, it can also, in severe cases, cause dangerous drops in blood pressure. So it is crucial for individuals with hypertension to maintain adequate hydration so that they can be able to prevent or so that it can be able to help them regulate the blood pressure and prevent the complications that would come about as a result of that. So thank you for that comment, Mercy. And the key thing here is more of individualized care, both in terms of fluid management and the nature of physical exercises that you are instituting on this particular patient, so that now you can be able to achieve the key outcome at the end of the day. We have another concern from Onesimus. He's asking, kindly give a clarification on the role of hydration and micronutrients in muscle atrophy.
Thank you, Onesimus, for that question. So you do understand that your muscles are also composed of water. Cellular dehydration can trigger procatabolic signaling, increasing protein breakdown in muscles, thus suppressing synthesis. Thus, the person or individual or adult does require to be proper hydrated at all times. Otherwise, the dehydration will just induce more muscle loss. For the micronutrients, as earlier touched on, we have vitamin D, we have calcium, we've got zinc, and all have very defined and specific functions. I try to touch a bit on them. Vitamin D helps with calcium utilization and mobilization and absorption, which is vital for muscle contraction. We've got B vitamins, B6, B12 that are involved in protein and carbohydrate metabolism. That's helping convert food into energy, which is used for basic muscle functioning and repair. You need the repair for you to be able to make muscles. Calcium is crucial for muscle contractions and nerve signaling, which is needed in muscle functioning and also for protein synthesis. Zinc plays a role in protein synthesis, in cell division, and general immune support, which are all very important for muscle growth and repair. Thank you.
Well, thank you very much for that elaborate explanation on that particular question. I believe it is now clear in terms of how the micronutrients play a role in muscle recovery. And with that, I believe from my end, I'm not seeing any other concerns from this particular presentation, so I don't think I'm locking anyone out from asking their concerns with regards to today's topic on muscle atrophy and how we manage it with nutrition, how it's related. So without further ado, thank you very much for joining us. And we say we'll have more sessions to come, which are usually on a monthly basis. So stay tuned, keep logging in so that now we will be able to benefit from the information that is being shared. Perhaps Ms. Vanessa, you can give your parting shot as we conclude.
Okay, so generally, I hope we've got some takeaways from this, and more so for everyone in the clinical setting. I forgot to mention that muscle atrophy can begin within hours of disuse in our wards. So everyone should be very aggressive with how they help support, because the worse it gets, the bigger the implications, the worse the functionality status of our patients. And so it just will increase the stay in our hospital. So more or less, that was it for today. Hope to have another session again to just dive deeper into this, maybe break it down and go into deeper lengths. Thank you.
Yes, from the takeaway, I believe from my end, it's more or less we have to work as a team so that now we may be able to achieve the desired clinical outcomes of these particular patients, because you can see there's quite a very big role that is going to be played by the physiotherapists when it comes to them instituting what sort of exercises would be favorable for your patient, depending with what they're suffering from. So you can get like that is not the task for the insurance to handle, as it is not their within their scope of practice. But collaboration with other healthcare providers would go a long way in helping us be able to achieve the desired outcomes at the end of the day. So thank you very much, and God bless.